Mr. Chairman, many thanks for the kind introduction. Dzień dobry from my side and good morning. So I will host this session on the role of the cerebrospinal fluid for diagnosing MS. And the first slide are my disclosures. And probably my main disclosure is that in our department, we do more than 5,000 CSF analysis per year. Of course, not only in MS patients, but also including MS patients, which may be relevant for my personal opinion and my approach towards diagnosing MS, but also in other neurological diseases. So I would just like to share two major points before introducing our combatants on that probably very timely and very clinically very important topic. And the first thought I want to share with you is, of course, diagnostic criteria, because you may all know that they just recently changed and they may be in the nucleus for this whole discussion. And as you know, the diagnosis of MS is based on dissemination in space and time. And this concept is as old as Charcot in the 19th century, and all criteria we had so far, Schumacher criteria, Poser criteria, and also the revised McDonald criteria base on that concept that you need 2 or more objective CNS lesions and proof of chronicity over time. And that was also true for the 2010 criteria headed by Chris Pohlman. But as you can see, not going into detail now on all these little complicated issues on the MRI criteria, there is no mentioning of CSF at all anymore, which was a little rebutted by German colleagues in the Annals of Neurology when that came out in 2011. And the only point in these criteria where the CSF still played an important role was in primary progressive MS, where you of course also have MRI criteria, but as you can see, there is the CSF still in, but nevertheless you don't necessarily need the CSF to diagnose PPMS, because as you can see under point 2, you need 2 out of the 3 criteria, and you can easily also diagnose MS based on the criteria A and B mentioned here. And without CSF, but still the CSF does play a role in this diagnostic criteria. Well, that all changed with a recently published, roughly almost 2018 McDonald criteria, because it was published just before Christmas, where the concept remained the same. So we're still diagnosing based on the dissemination in space and time. And if you have 2 clinical attacks and objective evidence of 2 or more lesions, then you don't need additional criteria if, and that will be my second point, there's no better concept. So if you're sure that it's really MS. However, if there is only evidence of 1 lesion, you can replace clinical criteria by go for a diagnosis in the case of a second attack, or you can replace clinical criteria by, of course, MRI, as it was before. And the new point is this one here, that in the setting of only 1 clinical attack where chronicity is not yet proven, you can, of course, prove that by another clinical attack or by MRI as before, or, and that is a new one now, by presence of oligoclonal bands isolated in the CSF. So again, CSF analysis does play a role, and because that is very important to me, that is again mentioned here, so that is new to the 2010 McDonald criteria. CSF-specific OCBs will allow for a diagnosis of MS to be made if there's no better explanation and if there's dissemination in space also proven. So why is that? That is briefly shown on the 2 next slides. A very recent study published in Brain from the colleagues in Barcelona, analyzing a cohort with a clinically isolated syndrome with a decent amount of patients, roughly 400. And what you can nicely see if you focus on the right-hand part of the slide, that in the setting where there is no clinical dissemination in space or time, but you have evidence for more than 1 lesion, oligoclonal bands do play a role, whether the outcome will be MS over time or not. If they're negative, it was like 26%. If they're positive, it's over 60%, so there's a huge gap, and that is probably the groundwork or the foundation for the new criteria. However, if you look at the setting where dissemination in space is proven already, the presence of the oligoclonal bands only yield a marginal effect of about like 8% if they're present or if they are not. Well, you can see that although the number is large in that study, the individual subgroups are not that big, so that probably remains to be further studied in really multi-center cohorts. So it probably may be one point of discussion in a minute. So why do we have that issue at all? And of course, our main concern is misdiagnosis and missing multiple sclerosis on the one hand, or misdiagnosing other conditions as multiple sclerosis. And that may be the case was nicely shown in that recent paper in Neurology. I found that very strong point and very honest. Probably, as you all know, if you go to your heart, we have these patients. I have to admit, in Erlangen, we also have these patients. And some of the most common misdiagnoses are mentioned up here. So it's migraine with unspecific lesions, it's fibromyalgia, which is of course difficult to diagnose, conversion disorder, or even conditions where we don't know what it is, but it's certainly not MS. And if the treating physicians were asked, how did that happen? You see that in a large amount of cases, 60% over-reliance on the presence of MRI abnormalities meeting the criteria and thus confirming the diagnosis of MS was one of the main reasons. So relying purely on MRI may mislead us in our diagnosis, and that brings me to my second point I want to make, that of course the criteria are there to diagnose MS, but they always involve the concept or a concept of no better explanation. So of course, as you may certainly know, there is a huge differential diagnosis of MS, and this is just two publications very nicely elaborating upon this. So this is one I give to all of our residents to read when they come to the clinics to understand how difficult that can be and how important that can be, and what is in the mix in the differential diagnosis. And that is actually a crucial part of the all the diagnostic criteria, being McDonald criteria, or the new criteria just recently published, that it is very important for us to recognize that these criteria were indeed developed and validated to identify MS or patients who have a high likelihood of converting to MS from a typical clinically isolated syndrome. So it's not differential diagnostic criteria. And even the criteria now do not only mention oligoclonal bands directly as positive criteria, but they also mention them in a way as negative criteria, because it's clearly stated in that paper that one should integrate, besides history, clinical exam and imaging, also laboratory evidence, and that of course includes the CSF, and that we need an MS expert, of course, to make the diagnosis of MS reliable or to rule out an alternative diagnosis. And based on that, it was concluded in that manuscript that there should be a low threshold for additional MRI analysis, including the spinal cord and also the CSF if the brain MRI is not conclusive, if the presentation may be somehow not classical, and that may include primary progressive symptoms. If there are atypical features, that may particularly also include, and was mentioned, bilateral optic neuritis, and also include populations in which is MS not that common. So to conclude that short introduction, I think the crucial points to tackle are the new diagnostic criteria, how important is CSF there, how important is CSF for you in the differential diagnosis, and probably one other point which I didn't have the time to talk about, what yield will be within the CSF besides oligoclonal bands if we look at newer methods of analysis. And that being said, I'm looking forward to our two combatants, whether we really need that in clinical practice or not. And I would invite you now for your vote, whether you think that diagnosis of MS can mostly be made without CSF, or whether we really need that. So I would kindly ask you to take out your cell phones, go into the app, and take your vote. And I'm pretty interested whether we get a similar clear result as in the first presentations, and whether that will change with the pro and con talks like we had that before. So again, it's a closer race than the one we had before in the beginning. Yeah, so probably we can stop here and leave it as it is, because that probably perfectly sets the stage for a good discussion. It's about a 50-50 decision. Let's see if we can revert that 45 to 55 vote with the next presentations. And to start with this, it's my particular pleasure to ask to come on stage Professor Jacek Lozi from Poznan in Poland, who is actually a very active combatant in this CONI concept. He gave already a lot of talks the last year, so he's very experienced and probably bringing in his opinion. He's a professor of neurology and at Poznan University of Medical Sciences, and the head of the Department of Clinical Neuroimmunology, and also the chair of neurology at Poznan, where he is acting for years with a special interest in clinical neuroimmunology and also the CSF. So Jacek, we're looking forward to your talk and to your presentations. Thank you.